Hello and welcome to this Facebook Live seminar. My name is Alison Schofield and I'm a Tissue Viability Service Lead and Clinical Nurse Specialist, also with a background in district nursing. Today we're focusing on how to manage and prevent diabetic foot ulcers. So now we'll move on to the presentation entitled Diabetes and the Effects on the Lower Limb, Managing and Preventing DFUs. So our learning objectives for this evening are to understand the anatomy and physiology of diabetes and the effects it can have on the human body, to discuss the overall health economic burden of this long-term condition, to explore how diabetes can affect the lower limb, to understand what is involved in the assessment of a patient with diabetes, and what should be considered when trying to prevent and treat patients with or at risk of diabetic foot ulceration, known as DFU. I want to point out at this point that we have specialists who work with diabetes and with diabetic foot ulceration. I come across these in my everyday practice, and I'm sure you as healthcare professionals will see patients and will have family. Yourself, you might even be diabetic, and so it's really important that we understand all the impacts and what to look out for. So what is diabetes? Diabetes mellitus occurs when there is an inadequate uptake of glucose by the cells of the body, and that results in raised blood glucose levels. So that's why if somebody has diabetes, we monitor the blood glucose levels. So let's look into it a little bit further. The anatomy and physiology of the digestive system is vital. And so what happens is that we eat the food, it goes through the esophagus, down into the stomach and the small intestines. There it breaks down the carbohydrate into glucose. The glucose then enters into the bloodstream. The gastric hormones promote insulin in response to the glucose. That's a normal function. But in diabetes, insulin is either produced but resistant to its effects, or there is a lack of insulin being produced. Glucose is then unable to enter the body cells effectively, and this results in a buildup of glucose in the blood vessels, which then can damage them. There are two types of diabetes, so let's look at type 1 first of all. We often refer to this as a juvenile diabetes, and that's because it's more common in children, but it can be diagnosed at any age. It is an autoimmune disease that permanently destroys beta cells in the pancreas and means that the body can no longer produce insulin. So then the person requires insulin injections to manage the diabetes, so giving insulin to the body that it cannot produce. Then we have type 2 diabetes. This was once called adult onset diabetes, also known as non-insulin dependent diabetes. Now we do find it in young children and adults, and that's probably because of lifestyle changes, diet changes, and we do have an increase in childhood obesity. This occurs when the insulin is not being used effectively by the body, and it results in insulin resistance and we get hyperglycemia. In the advanced stages of type 2 diabetes, this may lead to damage and the insulin producing cells, the damage of those, and then this leads to insulin deficiency, and then the person may also require insulin injections, as with type 1 diabetes. 90% of patients with diabetes have the type 2, so it is much more common. And typically this serious health condition is the most poorly managed out of the two forms of diabetes. We were discussing this just before this, we're going on live on air this evening, and there's many factors relating to that. And often it can be that the person just doesn't want to accept the diagnosis, or they can't see the effects that's occurring. So diet and lifestyle are not managed. So let's look at the anatomy and physiology again. So we have there three diagrams on the screen. We have the healthy system, so we intake the food, it goes down into the stomach, it breaks down and we have the glucose produced, insulin is produced through the pancreas, and then that aids the muscle function. So we've got strong working effective muscles. In type 1 diabetes, we don't get the insulin production, so then the muscles are affected and they can be weak. In type 2 diabetes, we have a low insulin production. So again, we're not getting the energy, the production through into the muscles, and then the tissue structures can be affected. So the risk factors along with diabetes: age, increased risk for 40 years and over. Patients who are people who are obese, who are particularly overweight, with that larger area in the middle, that stomach region. Ethnicity: type 2 diabetes is 2 to 4 times more likely in people of South Asian, African Caribbean or Black African descent. Genetics also plays a part, 2 to 6 times more likely to get diabetes if you have a parent, brother, sister or child with diabetes as well. And hypertension, there's evidence and studies to say that they can exist together. So if somebody has hypertension, then they can be more likely to get diabetes. What are the symptoms of diabetes? So it's important to look out for these with your patients, with your family, with your friends and with yourself. So tiredness, always feeling hungry, typical teenager, I can hear you say, but it's not just 1 or 2 factors, and it's not all the factors, remember. So what else is there? People experience sexual problems, always feeling thirsty, drinking water and even at night. Numbness or tingling in the hands and feet. Constantly going to the toilet, frequent urination, even at night as well. Systemic weight loss, so that's a rapid weight loss. And wounds that just won't seem to heal or budge. Blurry vision and vaginal infection. So any of those factors, get a few of those, then it's important to seek help. So the complications of diabetes, and I think sometimes these are unseen, so it's important to be aware of them, to make our patients aware of them if we have uncontrolled diabetes. So we have a risk of stroke, we have a risk of eyesight problems, retinopathy and blindness. We can get kidney damage, and that can lead to permanent damage, and people can then have to go for dialysis and even kidney transplant. Cardiovascular problems, including heart attacks. Peripheral neuropathy, so the nerve endings are damaged. People lose sensation in their lower legs and feet. This can lead on to then diabetic foot ulceration, which can produce infections and osteomyelitis and amputations. So there is a health economic burden attached to diabetes, as with all the other wounds that we know. 415 million people worldwide live with diabetes, and 3.6 million of those are in the UK. So it is an extensive problem and it is growing. It is estimated that 193 million people will be living with it undiagnosed. Worldwide figures suggest that foot ulcers develop in 9.1 to 26.1 million people with diabetes, and we know the burden of wound care, £5.3 million. Diabetes is up there in the top 3. There is no cure for the condition, but it is estimated that 3 out of 5 of the cases of type 2 diabetes could be prevented or delayed by a healthy lifestyle. Amputations are caused by a DFU failing to heal. There is an amputation occurring every 30 seconds from a diabetic foot related complication. And the risk of death at 5 years for a patient with a DFU is 2.5% higher than without. More than half of all DFUs can become infected, and approximately 20% of moderate or severe infections will result in amputation. There are international guidelines regarding infection of diabetic foot ulcers, and so it's good to be aware of what they are. Mortality after diabetes-related amputation exceeds 70% at 5 years. So the effects on the lower limb of having diabetes. Many risk factors can contribute to problems with the lower limb, including insufficient medication, so that could be relating to the insulin. Poor nutritional status and diet, so if the diet's not controlled, the diabetes isn't controlled. Poor foot care. It's so important for people to check and look after their feet, to wash their feet, apply emollients, keep them intact, nail care, and if they can't do it themselves, then to ensure somebody else is doing it for them. We can sometimes see non-compliance, and again that can be back to just the avoidance and not acknowledging and recognise the problems and issues that they have. And work commitments. We all have busy lives, and diabetes can affect people at all ages. So sometimes we're so busy, we sometimes neglect the basic care that we need, that patients with diabetes need to ensure that they're having. Other factors leading to the development of foot ulceration in diabetes include neuropathy, so that's where the nerve endings are affected, the small blood vessels in the lower feet, ischemia, and then we can, if they get a break in the skin, ulceration, this can lead to infection. Dry skin can become a problem, so it dries, it cracks, it's a portal for bacteria to get in. And diabetic neuropathy is one of the most common of the many complications of diabetes, and the foot is particularly vulnerable to the effects of this. Poor foot care, we've kind of mentioned that can result in ulceration. So if somebody's walking around with no shoes on, no socks on, not washing the feet, they become dry and cracked, fungal infections. And usually the patient is not aware of the damage being caused due to the neuropathy. They don't have that sensation and feeling. They could stand on a rusty nail and they wouldn't know about it. Daily foot inspections are essential for a patient suffering with diabetes. So they may have compression stockings on, for example, because they're dealing with venous insufficiency. But it's important for them to remove items and to check their feet every day. Another effect on the lower limb can be Charcot foot, and this can be a complication of diabetes where the bones weaken, and they weaken enough to cause fractures. Neuropathic patients with a tight Achilles tendon have been shown to have a tendency to develop the Charcot foot. And as this disorder progresses, the joints collapse and the foot takes on an abnormal shape. So you can see from the photograph there and the diagram, and the bottom of it almost looks like a kind of a rocker type appearance, type shape. Signs and symptoms of Charcot foot are that it's warm to touch, there's redness in the foot, swelling in the area, pain or soreness, and I can immediately see you thinking cellulitis. Yes, the signs can mimic cellulitis as well, but if somebody's got diabetes and they've got neuropathy, it's important, if you get these signs, then to get specialist help. Treatment options of Charcot foot include immobilisation, offloading of the foot, so that can be with custom-made shoes, bracing of the feet, and also moderating their activity. This can be difficult for patients because it can have an effect on them, obviously, on their mobility, their activities of daily living, and as well their psychological status. So general recommendations for a patient with diabetes should always consider the following. Stop smoking. Smoking, we know, does affect the arterial system and those small vessels. Weight management, of course, because if somebody is obese, overweight, then that can lead to type 2 diabetes. So this is including our interdisciplinary teams and looking at lifestyle changes. Change of diet, good glycemic control. There's been a lot, you've probably seen a lot of programs on TV regarding diabetic type diets. You might do some of these diets yourself, and they have been proven to be very effective. Foot care, we've said, and that might involve other professionals, podiatrists, for example, or patients in care homes, for example, patients in their own homes. We've got district nurse going in just to check the feet. Keeping the feet warm as well. If the feet become cold, then it can affect the circulation. And the appropriate footwear, no flip-flops. It's got to be a good fitting with a good sole footwear, which will help protect the foot. They want to avoid the injury. Remember the rusty nail. Don't want anything that they're going to tread on in the house, out and about. So it's because they may not feel that injury, and so that it may be presented too late to action. And if they do get an injury, they need to be attending a clinic, a GP centre, promptly, because it needs urgent action. When we're doing a diabetic foot assessment, patients should undergo an annual foot assessment. So this will be in your podiatry teams or your specialist teams. And we can categorise when we do a diabetic foot assessment as a low risk, so there are no foot problems at all. A moderate risk, so the foot does not have full sensation or pulses, or there is a deformity or a mild infection. So with these foot assessments, you might find that there's the foot pulses are tested with a Doppler instrument, for example, and the foot will be checked for any signs of breaks. High risk, the foot has a severe deformity and has other serious complications, and they have to be urgently referred to the MDT diabetes team, and they could have a moderate to severe infection. It's so important to get that person seen urgently. Assessment of the foot should include the vascular status, so I mentioned the Doppler, so this might be that the ABPI is undertaken, ankle brachial pressure index, remember that from the venous session we did last time, and it also might be TBPI, so a toe brachial pressure index, or it might be that the pulses are palpated or listened to in the feet. We need to check if a person has PAD, peripheral arterial disease. This affects the small vessels and can lead to complications. A patient may have engorged veins, so this is large bulging veins that results of hypertension in the superficial veins. That loss of sensation, so those damaged peripheral nerve endings, loss of sensory modalities. Now that means things like cold and heat, temperature, the patient can't feel it. So they could have the feet resting, you know, on a cold day, or put them in front of the fire, rest them on the radiator, and they could develop burns. Pressure ulcers, they could develop those. So we have to think about putting preventative measures in to prevent that action. And the neuropathy. With foot deformities, you could see wasting and weakness of the intrinsic muscles. There may be absent ankle reflexes. So if you do an assessment of your patient, and just ask them if they can sort of wiggle their ankles, move their feet up and down, and sometimes they might have that fixed ankle joint. A deformity or clawing of the toes, so the toes are kind of like in a claw-like fashion, bent over, and the loss of the arches in the foot. The Charcot foot can lead to osteoarthropathy. Can't say that with my teeth in. Skin changes, increased skin temperatures, there's a lot of loss of sweating function, you can get dry skin and that build-up of callus. And it's often the podiatrists who have those debridement skills to get the callus away, so to prevent cracking and infection. The edema, the swelling in the feet, and if a wound is present, it can become necrotic and gangrenous. So prevention is always key in wound care, and never more so than in diabetes. So the key advice to follow is the nail care. We need to get that emollient on for that dry skin. Good footwear. And if you want to know what footwear, then your podiatrists are well placed to give advice on what that should be. Daily self-examination of the feet, and we're talking so much about self-care these days. It is so important. And do not walk in bare feet, no flip-flops, and that debridement of the callus. So key advice is to check footwear and hosiery before wearing. So if somebody's wearing their hosiery, check that it's not too tight around, because if they've got neuropathy, they might not be able to feel it so well. So we don't want it too tight around their toes. That footwear's not squashing around the sides of the feet. Any break or shoes that are falling to pieces should never be attempted. It's got to be a good fitting shoe. Hot water bottles, I've seen a few of these in my time, where hot water bottles put into the bed at night, feet put on them, and of course if you can't feel that heat, you could end up in some severe burns. Getting in the bath or the shower to check the temperature to make sure that it's not too hot and we're not going to get some scalding or burns as well. Don't use home remedies like, you buying your own plasters, cord plasters. It can cause soggy maceration to areas of dry callus. It's better to go to the professionals. And what to do, and to tell the patient what should they do and the appropriate person to contact if they develop any problems with their foot. So with that, first contact is the GP, the practice nurse, the district nurses, or if they're already under the care of the podiatrist. So holistic treatment with any patient in any situation and in all wound care is essential. So the ultimate objective here is to prevent amputation, and this can be achieved by considering some of the following: education in, on or around the correct medication that they should be taking, the footwear, the correct footwear, active treatment of the wound by debridement, so we can use the TIMES framework to formulate what we want to do with the wound, antimicrobial wound dressings if they're appropriate, the management of the exudate, because if the surrounding skin becomes soggy and excoriated, there's risk of further breakdown, and offloading, the reduction in the pressure wherever on the part of the foot the ulceration has occurred. So offloading and reduction in pressure, this is a fundamental principle in diabetic foot ulcer management. It's important to shield the wound from the pressure generated by the weight bearing due to walking, sitting or lying. If you think the full weight of the body is going down through the feet. So effective offloading of the foot can increase healing rates by up to 90%. So there are devices to offload, and they include non-removable devices such as a contact cast. Now this will be done by your specialist teams. They have the training and they know how to apply these. And this is the gold standard for the under the foot DFUs. There's a type of plaster of Paris device which is provided from Essity. And there's a Delta Cast conformable which has a synthetic casting tape. And there are removable devices as well. So you've probably seen them offloading boots and shoes, and shoe inserts. There are some that you can remove parts of the sole and it provides an offload wherever the ulcer may be. Now we must work with our patients. It's so important. They are part of this treatment plan and it is about them. So we want to make sure that we have the right device because we want them to wear it and use it. So that has to be a key consideration for treatment decisions. The considerations when planning the care of a diabetic patient with a foot ulcer is obviously their mobility. We don't want them to be sitting because they've got a cast on or a device, or they've got a painful foot ulcer. We want them to keep active and walking. That's really important. Their regular activities of daily living, do they go shopping? Do they go gardening? Are they still out and about working? Their support network, so we need to ensure that they've got the right contacts and to provide that support, and that they're concordant with the device that we are wanting them to wear. I just want to talk a little bit about a Sorbact technology. So this is a range of wound dressings for safe infection management and prevention. Sorbact technology binds and removes bacteria and fungi via very simple physical principles. A broad range of evidence demonstrates its safety and efficiency, so this can be used for acute wounds and chronic wounds. So the mode of action with Sorbact technology is that it uses hydrophobic properties, enabling them to irreversibly bind bacteria and fungi in the moist wound bed. You can see with the diagram on the screen there how the bacteria binds to the dressing, and when it removes, they are lifted away. There is also the Cutimed Sorbium range, and these dressings are the only superabsorbents to utilise hydration response technology, HRT. HRT is the unique design concept that meets the challenges of modern wound management in a unique way, providing superior exudate management and effective wound bed preparation. Cutimed Sorbium dressings offer clinically and cost-effective treatment while helping to give patients improved quality of life. So we're just going to look at some case studies now in using some of these products. So with case study 1, we're going to look at the use of Sorbact technology with dressings with a diabetic foot ulcer. So just to give you some background of this particular case study, there were 19 patients in a case series, and there were 29 diabetic foot wounds. The primary objective was to evaluate the ability of the dressings to reduce the symptoms and signs and risk of infection. The secondary objective was to assess maceration, the sogginess around the wound edge, any malodour, and healing for change during the study, and to obtain patient and clinician feedback on how to use the dressing. Was it comfortable? Was it easy to use? The treatment period was over 4 weeks duration, or until the wound had healed. And of the 29 wounds, 24 had a positive history of infection prior to the enrolment in the study. 22 of the wounds showed 2 or more signs of infection. So the outcome of using the Sorbact technology in these diabetic foot ulcers was that all the wounds had 1 or no signs of local infection. All the wounds had reduced in size from enrolment to the end of the evaluation period, and 8 of the wounds had healed completely, and a further 20 showed a reduction of 50% in size. Case study 2. We have a 60-year-old with type 2 diabetes. They've had previous osteomyelitis, which isn't uncommon when you have a diabetic foot ulcer occur. It is one of the complications. And in this patient, it led to amputation of both second toes on this foot. Despite good wound care and appropriate offloading, the wound just failed to progress. So the treatment regime that was put in was Cutimed Sorbact, used post-operatively following removal and discontinuation of gentamicin beads. Now these are a string of antibiotic-loaded beads that are put in under surgery and then later can be removed. The outcome for this patient was that they made good progress, and 3 weeks later the wound was fully healed, and that was by week 15, so a really good outcome there. Case study 3. This is a patient with a long-standing diabetic foot ulcer, 60-year-old gentleman, type 2 diabetes, and had profound neuropathic deficit. He had amputation of the forefoot, and it left him with an altered biomechanics, so it's an altered gait when he was standing and walking. And he had a non-healing, heavily exuding wound which had not responded to the gold standard therapy. So a new treatment range was put in with the Cutimed Sorbium Sachet S, and progression was monitored with photographs measuring exudate volume, as good wound assessment should be. The investigator and the patient rated the treatment and the dressing performance, patient comfort and handling on application. So the outcome here is that the wound made good progress and was fully healed by week 12. So with the use of a superabsorbent dressing, controlled the excessive exudate and allowed the wound to heal. And when it was costed, it was much more cost effective than using negative pressure wound therapy. So case study 4. This is a diabetic foot ulcer that had necrosis. It had diabetic foot gangrene. A 62-year-old female this time with diabetes mellitus, this patient wasn't primarily insulin dependent, but they also suffered with renal failure and coronary heart disease, so a lot of comorbidities there too. The wound was necrotic, there was moist gangrene and reddening and swelling to the forefoot and ankle. They had transmetatarsal resection of the first and second ray, which means the toes, and was performed followed by extensive basically debridement of the sole of the foot. The treatment regime was post-operatively that wound management was lengthy, and after 8 days of topical antimicrobial therapy with Cutimed Sorbact swabs and absorbent pads, which were changed daily, the wound bed was granulating and became infection-free. So that's a good result. Case study 5, and this involves infection. So infection is a high risk problem in diabetic foot ulcers. So this is a gentleman of 78 years old. He had a right femoral angiogram, so that's a test to look at his femoral vascular arterial system, and an anterior tibial artery angioplasty, so that's to open up the artery. That's a surgical intervention. Following which he developed a pressure ulcer on his right heel. He was discharged home with topical negative wound pressure therapy and was subsequently discontinued due to, there was no progress in the wound, so it was decided that to discontinue that therapy. The wound dimensions were 4.5 centimetres by 2.5, bone was exposed and there was a 1 centimetre undermining. Simple X-ray, which is indicated for osteomyelitis in diabetic foot ulceration, did actually show signs of osteomyelitis in this case. Antibiotics were commenced for 6 weeks, and the patient had been informed by the consultant that amputation was probably going to be the only option available, but they were going to wait 6 months just to give it a final chance, because the patient was very distressed and didn't want to go through with the amputation at that point in time. It's a big decision for patients, and we must make sure everybody has all the informed decisions. And for this particular patient, after starting on a treatment regime of Cutimed Sorbact swabs, the dressing was changed daily and then went to alternate days, and around week 6 the wound then measured 2.25 by 1.5. So remember those measurements before of 4.5 by 2.5. So we've got a large reduction in size. The ultimate outcome was, due to the success with Cutimed Sorbact, the patient was discharged with no immediate plan to amputate, which was great news obviously for the patient. At week 13, granulation tissue covered the previously exposed bone. Week 27, the wound now measures 0.75 centimetres by 0.5, so we're at near healing by this point. The patient was so happy and the wound did go on to heal, so that saved an amputation. So in summary, all patients should undergo an annual foot assessment to identify the risk of developing lower limb problems. Assessment of the lower limb should include the vascular status, the sensation, and this may be performed in different ways, the sensation checks. Foot deformities and any changes to the skin with a diabetic patient. Concerns regarding the lower limb should be referred to the multidisciplinary team, I can't stress that enough, and treatment of a DFU should consist of effective wound care, and that includes the debridement, the good footwear, the offloading and foot care. Prevention of a DFU developing or any complications arising following a DFU should be, the priority should be to prevent infection and to prevent amputation. Following this seminar, I want to ask you all to check your feet. Then I want one person you know to do the same, and carry it on, spread the message, and post your comments on @JobsUK on Twitter, or below in the comments box on Facebook once you have done it, and use the hashtag #MyFeetMatter. Let's get everybody checking their legs and feet. Free education and training is available via the Essity Academies, and there are 31 modules available for us, and they include anatomy and physiology of the skin, factors affecting wound healing, infection management, surgical site infection, litigation and the law and the NHS, and improvement of the assessment of wounds. And if I can just mention as well, I would like you all now, as soon as you're on Facebook, if you search in groups for Lower Limb Clinicians UK, which is a group I started 10 weeks ago, and for all healthcare professionals who work within the lower limb. We have vascular specialists on there, podiatrists, TVNs, district nurses, general nurses, and we have over 1,000 members now, and we all come together to discuss all these aspects of conditions of the lower limb, so please join us. So now we'll move on to our real-time question and answer session. What is the best way to make our patients aware for self-management? And I think it's like with anything, we get asked this a lot kind of in compression as well and around concordance, is if we give patients if we inform them with all the knowledge so they understand their condition and then they kind of accept it and take the accountability of that. And just simple basic things like checking the feet, washing, good skin care, the foot care, everything we've kind of talked about. If you get them to take that ownership to their family, their friends, and make sure that they're just absolutely fully aware of all the information. We give them, we have patient leaflets in our trusts. We can give them websites to access and to look for, to gain information. So thank you very much. Really good question. We'll see if we can get on to our other questions. But while we do, I just want to, a question that possibly might have come up, which I get asked a lot in my practice is, well, what dressings, types do you use? Obviously, we looked at the Sorbact type of dressings today, and we also look to your obviously local formulary. If you get a diabetic foot ulcer that is necrotic and it's dry, and we say leave that intact and refer on to the specialist. The specialist might actually perform sharp debridement in these cases, but it might be that it's part of the body's natural protection, necrosis on the heel, for example. So when we don't want to go in there and start debriding and make a soggy mess with that, so we will aim to keep them dry. Can we use compression if somebody's got a diabetic foot ulcer, if we're managing their venous disease? Yes, we can. Obviously, we have to be aware that they've got neuropathy, loss of sensation, so we can still apply it, but we need to obviously be very cautious and we need to check. And it might be that you need to use reduced compression, so you will be liaising as the MDT with all your specialists within that. Okay, we have a question coming up on the screen. So if a patient has a diabetic foot ulcer, how long would you wait to test for osteomyelitis? Good question. Okay, so a patient's got a diabetic foot ulcer. Okay, so it depends. I mean, if the wound is, we know there's a bone visible there, then we want to make sure that we've got the sampling tests of that bone. So anybody who's got a break in their skin integrity, refer them to the specialist, and then they will decide, do the patient having x-rays, do they need that bone sample, tissue samples to send off, and it's simple x-rays. It might be then that they go on to have MRI scans for the osteomyelitis, but kind of don't wait around really, sort of, just get on with it and send them for the tests. We have another question coming from, this question from Joy Tickle. Hi Joy Tickle. Do you feel that the poor diets some of our children will eat will lead to their increased risk of diabetes. Oh my goodness, absolutely. And that's what we were saying with type 2 diabetes, how it has become more, used to be called adult onset, it's become much more prevalent now in children. You know, yeah, you know, the McDonald's generation, if for want of a better word, it's definitely an increased risk, and I think if we don't do something about it now, if we don't educate in our schools and we don't get it under control, then we're gonna see a phenomenal amount of more of type 2 diabetes developing, and then all the complications that come along with that. So question 3 is from Rachel. How do we all get professionals working together to support the patient? Yes, sometimes we work in silos, don't we, and work in isolation. But actually the National Wound Care Strategy is looking to address this, and we are looking at, especially in the work stream of the lower limb, of how we're going to come together and work more so we have got much more NDT working. In the future, there's going to be much more patients being managed in primary care, in community care. As part of the NHS 10-year plan around prevention and care at home. So we need to be working towards that. So first of all, conversation. Let's start talking to our colleagues, refer our colleagues on, and you know, do joint visits, joint clinic assessments, things like that. And do we have another question? Yeah, we do. Question 5. There we are. I have a resident with a wound that's just started. Her leg is looking red. Not sure if it's inflamed. Does she need antibiotics? And what is the best dressing to use for the wound to heal quickly? Okay, so first of all, you need to do that full holistic assessment of the patient, and if is it a diabetic foot ulcer? I'm thinking maybe it is, or is it a leg ulcer? So you're not sure if it's inflamed, is it hot, is it painful? Classic signs of inflammation and infection. And we always say a person needs antibiotics if they have signs of a spreading infection. So has the patient got an increased temperature? Are they systemically starting to show signs? It may be that you need to use antimicrobials onto the wound site if you're thinking it's looking locally infected. And dressings like what we've discussed tonight will also be useful for that. Question 6, Vicky Spires, what is the TIMES framework? Good question, and I'm so sorry, and if you didn't watch the last live that we did, and you might not be familiar with it, because I did go through it then on the VLU one, venous leg ulcer. But TIMES framework it's a wound assessment framework. If you can Google it, you can find it online, and it compromises as T means tissue, I infection, M moisture, E edge, and S surrounding skin, all relating to the wound. A brilliant framework for within your clinical practice. Question 7 is from Sherry Lee. Thanks, Sherry. On a low-risk diabetic, is compression therapy recommended? I think I kind of slightly mentioned that, but just to reiterate that again, yet patients with diabetes can have compression therapy. They might have venous disease, edema, and we don't want that to get out of control. So if you look at that, for example, there's a new best practice document on venous leg ulcer complexities, and we address that within there. You can apply it, but you just have to be cautious and aware. If patients cannot feel, then we must be checking more often. And our final question we've got there, Rachel Rawlins. Hi, Rachel. Rachel's on our group, I think, on our lower limb group. I recognise your name. What can we do for a diabetic patient that ulcers are now healed but can't change their own stockings as they are elderly and obese? What aids can they use to do it themselves? So a patient who's wearing stockings, yeah, we do get that, don't we? People just say, no, nurse, I can't apply that stocking. There are aids on the market. There are various things that can stretch the stocking over and put the foot into. There's like the ActiGlide, like a parachute type of material. There's the Rolly, which is a lovely rubbery type device. And Marigold's gardening gloves, so they can get a better grip too. Or can they ask a neighbour, a friend, a relative if they can help to apply them too? So this concludes our live training session. I'd like to take this opportunity to thank Essity for their support of this event. Essity have a range of educational resources that we've had a look at, and contact details are on the screen. I hope this has really helped you gain a better understanding of the management of diabetic foot ulcers. I know it has for me. And if you've enjoyed this event, please like the JCN Facebook page and look out for details of upcoming events. We've got a few coming. Thank you very much and have a great evening.